Okay, we're going to start now. We're going to give a couple of seconds so people can, maybe waiting in the waiting room can, I see people waiting. Okay, we're going to begin. Good morning, buenos dias. Welcome to our fourth webinar of the 2022 National Latino AIDS Awareness Day campaign. My name is Luis Alberto Mares. I am the Director of Community Mobilization Programs at the Latino Commission on AIDS, and today I'll be your host and part of the webinar as well. This year, NLAT 2022 represents the version number 20 of NLAT. And in 20 years, NLAT has evolved, changed, and matured. From the beginning, it was a poster campaign providing information about HIV and asking people to get tested. Through the years, we have included many other things into the call of action. So now we promote also, continue promoting testing and prevention as well. But prevention includes now things like PrEP. And that's going to be a topic that we're going to talk about today. Last year, NLAT acknowledged that we were on this epidemic for 40 years in the United States. This year, we're focusing on the advances of science that have been happening in the recent years. We're focusing more on the new options that we have to treat and prevent HIV. There's a new PrEP option as well, injectable, that we can use every 2 months. So this topic's PrEP, if it's going to be, I've mentioned, the topic of today. So today, as I mentioned, we're going to talk about PrEP, but it's a report on the data collected on PrEP since 2012, when it was approved for the first time, until last year, 2021. The data shows that PrEP is being utilized, how it's being utilized, and shows certain inequities in distribution. Today, Dr. Patrick Sullivan, a principal research scientist from AIDSVu, is here with us to present this data and to answer your questions about the topic. Patrick is the Charles Howard Candler Professor of Epidemiology at Emory University Rollins School of Public Health and co-director of the Prevention Science Core at Emory Center for AIDS Research. He has worked in HIV prevention for nearly 30 years. Prior to joining Emory faculty in 2008, Patrick served as an EIS officer at CDC and for 12 years in CDC Division of HIV and AIDS Prevention. He has served as chief of CDC HIV Behavioral and Clinical Surveillance Branch and the deputy director for scientific support in the NIH-funded HIV Vaccine Trials Network. Dr. Sullivan research focuses on HIV among men who have sex with men, including behavioral research, interventions, implementation, and surveillance. So with this, we're going to begin the webinar. All right.
Great. Thank you, Luis. And thank you all for attending. And what I'd like to do today is just share with you the results of some work that we've been doing to try to describe the patterns of PrEP use in the United States among Hispanic and Latinx communities, but also introduce a way to think about PrEP use equity. I think PrEP is an amazing tool to help reduce the risk of acquiring HIV. And I think it's important that we keep in mind that we want to make sure that PrEP rolls out in a way that it really reaches the people that need it most. One of the things that that could occur is if PrEP rolls out, but only to people at relatively lower risk for HIV, that actually could widen disparities in the HIV epidemic. And so it's critical that we monitor whether we're getting PrEP to the people that need it most. Next slide. So today, I'll start out by sharing some information with you about the data that we have on AIDSVu, and then Luis is going to pick things up from there and talk more about the implementation of PrEP programs and opportunities. Next. I'm going to talk a little bit about the background of AIDSVu and give you a summary of the recent analysis that we did about this question of PrEP equity. I'm going to show you where you can get the PrEP data on our AIDSVu website. So if you want to see what the data look like in your state or jurisdiction, I'll show you how to do that. And Luis will talk about PrEP use among Hispanic Latinx individuals, and then we'll have a discussion and Q&A. I think if you have questions as we go along, if you put them into the Q&A, that's great, and then we'll have a good starting point for the discussion. Next. All right, so the background. Next. I want to just briefly introduce you to AIDSVu if you haven't used it before. And Luis, in his kind introduction mentioned that I worked for 13 years at the Centers for Disease Control and Prevention. And most of the years that I worked there, I worked on producing data reports that look like the page you see on the right, with a list of jurisdictions and numbers and columns. And I think that these kinds of data are so important to understand and to monitor the epidemic, but I also think that not everyone takes in data in the same way. Some people really want to see numbers and columns on a page like that. Even within my own family, I know that some of my family members, one of my children in particular, just these numbers would not be terribly meaningful to him. And because we all take in data in different ways and detect patterns in different ways, we developed the AIDSVu platform, which is the map you see in the middle. And it's just a way of illustrating using these sort of heat maps where darker colors indicate more intense or higher numbers that let us get a different view of the epidemic. And so these are county level, this is a county level map of people living with HIV where the darker shaded counties are more highly impacted. And so from the first time, and this was the first time that county level data had been, a map of county level data had been produced in the United States, is when we did this on AIDSVu. And it really just gives you some different kinds of understanding of the epidemic. Some things I think we know and are familiar with that we see sort of hot spots or darkly shaded spots in many major cities. But this was also the first time that I really realized the impact of HIV in counties in the rural South that are south of Atlanta, south of Birmingham, through sort of relatively rural parts of North and South Carolina. And it tells us it's a map to where we need to take action. So AIDSVu is a partnership since 2010 between Gilead and Emory University. We visualize data and then we try and make insights out of that. Like, what do the data tell us about how we need to intervene? We try and make data easily available and accessible to people who need it, just to increase awareness and to help people make the best decisions about where to put resources. And we know just from user surveys and other ways of understanding who's coming that it's a place where all kinds of people come. Like, people in the public may come to find a place to get HIV tested. People living with HIV may come to find information about treatment or where to get treated. Researchers download data sets. Advocates use this to educate their representatives. So it's a nice sort of shared data source for people who are trying to end the epidemic. Next. Throughout AIDSVu's history, we started in 2010 with state level maps, which you see on the sort of upper left there, that's mostly yellow. And this was honestly at the time, other than what local health departments were putting out on a national basis, this was the most granular thing that was being produced. In 2011, we started producing county level maps, which you see on the bottom. We looked at one of those before. We also started adding city maps and at the level of zip codes. So you can see a map of DC depicted in blue. We had a new diagnosis mapping in 2011. In 2013, we started adding care continuum elements at the city level. So within cities, you can look in your city and see where each zip code is with respect to each step of the care continuum. We first added PrEP data in 2018, initially at the state level. On the above the line, we added county PrEP 2 years later. We've continued to develop our care continua. And this year, our addition is state PrEP data by race ethnicity. And this, by starting to break the data down at the state level by race ethnicity, we can really start to see where the gaps are and what needs to be done programmatically. Next slide. So just as background, PrEP was first approved for HIV prevention in the United States in 2012. And we sort of, it's a good question to ask, like, how much PrEP use do we need to really bend the curve of this epidemic? And so epidemic simulation models suggest, for example, that if we could get 40% coverage of PrEP use among gay and bisexual and other men who have sex with men with PrEP indications, we could reduce HIV incidence by 1/3. But we know that so far PrEP uptake has fallen well short of that goal. We also know that in the United States, Black and Hispanic Latinx people have higher rates of new HIV diagnoses than white non-Hispanic people. And people in the South have higher rates of new diagnoses than people in other US regions. And these last 2 points that I make, we're talking about PrEP. So how do new diagnoses come in? The goal of our PrEP program should be that we're getting PrEP to the people who need it most. We're getting PrEP to the communities within the US, whether that be by race, ethnicity, by sex, by geographic region, that we're getting PrEP to the people who have the highest rates of new diagnoses. And that's going to sort of shape the rest of the discussion about our data. Health equity is a term that we use to say that the access and use of the prevention interventions needs to be proportional to the impact of the health concern in the population. In this case, PrEP use should be in the same proportion as new diagnoses when we look by region or by race ethnicity. Next slide. And it's important to distinguish when we talk about health equity, we need to distinguish equality and equity. Equity is an approach that says we're going to treat everyone equally. In this case, if people are going to watch a soccer match, I think that's soccer, and there's a fence, we're going to give everybody the same, one step up so that they can see the soccer game. But what you see in this depiction on the equality side, that's an equality approach, is we're going to give everybody the same. That seems fair. But what you see on the left part of this picture is that for the tall person all the way on the left in the red shirt, they really didn't need a step up to be able to see that game. For the person who's in the middle, they are able to see the game, but notice that they're standing on their tiptoes in those pink shoes. And for the person on the right, the one step up was not the kind of resources that person needed to be able to see the game. And compare that to the equity approach, which says some people may not need anything from a public health program to be able to engage in their best health and access everything they need. Some people may need 2 steps up, and some people need a completely different solution, like the person who needs a ramp to be able to see. And that's an equity approach. We haven't given everybody the same solution on the right, but everybody reaches the same equitable outcome in terms of their ability to engage with the soccer game. Next. So we're going to focus on this piece of equity, and I'm going to present some data that I presented in Montreal a couple months ago. So these are still kind of fresh and not otherwise public yet. Next. All right, so we got PrEP data from commercial pharmacy, and we used that to count PrEP users by race and US Census region from 2012 to 2021. And in this data set, race ethnicity data were available for about 1/3 of the PrEP users. From an analytic point of view, we would like to see a much more completeness of race data, but we're also at AIDSVu fans of not letting the perfect be the enemy of the good. And so we estimated total PrEP users by assuming that the racial distribution was the same in the PrEP users who were missing race data in the data set as in those who reported the data. That's a limitation that I'll acknowledge again later and that we'll continue to try and improve on. But when you do this, you can now start making these maps in a way that are more nuanced. For example, this is a map that depicts the number of Black people using PrEP in 2021. Next slide. So then we also have to deal with this issue of equity that I was mentioning before. And the way that we account for that is the PrEP to need ratio. And that's a measure of, the PNR is a measure of PrEP equity. And basically it says we're going to make a ratio where the top part of that fraction is the number of people using PrEP in a group, for example, the number of Hispanic or Latinx people, and the bottom number is the new HIV diagnoses in that same group in a year. What we'd like to see is the more new diagnoses there were in 2021 among Hispanic Latinx people, the more PrEP was used by that same community. And so ideally, this PrEP to need ratio would be the same, for example, across racial ethnic groups. For years 2021, we're using the number of PrEP users in that year over the denominator of people diagnosed in 2019, since that's the most recent new diagnoses we have. So if you look at the infographic that's displayed here, this gives you another way to look at and think about this issue of equity. So for Black people in the United States, in the top two bars, represent 42% of all new HIV diagnoses, that's the blue line, but only 14% of PrEP users. Hispanic Latinx people represent 27% of new HIV diagnoses, but only 17% of PrEP users. And then the bottom line, white people who represent 26% of new HIV diagnoses account for nearly 2/3 of the PrEP users. Ideally, we'd like to see that the proportion of new diagnoses and proportion of PrEP users are the same in each group. That would be PrEP equity. And right now, we clearly have a situation that's not equitable. Next slide. So on this slide, there's a lot of data on here, and I'm going to walk through it one thing at a time, because I think there's a lot to take away from it. These numbers that you see, like the 26.3 in the upper left quadrant in purple, are the PrEP to need ratios. There are 4 quadrants, each representing one of the US regions. And then within each quadrant are 3 lines. A purple line, that's the PrEP to need ratio in white residents in that area. The yellow line is the PrEP to need ratio in Hispanic residents, and the red line is the PrEP to need ratio in Black residents in that area. So I'm going to give you a verbal interpretation, and then I'm going to make a few points about this. So the verbal interpretation of this, for example, in the West, is that in the West, among Hispanic people, there are 6.3 people using PrEP for every 1 new HIV diagnosis in 2021. In that same region, there are 27 white non-Hispanic people using PrEP for every 1 new HIV diagnosis in white people. So a few trends to point out. First, if we can click the first arrow, the Northeast here, all 3 lines have the highest PrEP to need ratio. That's the highest equitable PrEP use among all the US regions. So, so if we just compare the white lines, which is what the arrow is pointing to, that number is 47 for the Northeast, 19.5 for the South, 27 for the West, and 26 for the Midwest. Next, I want to point out that the US South, if we can click again, has the lowest PrEP to need ratio of any of the 4 regions. And again, that pattern holds across all the racial ethnic groups. Within each of these quadrants, there are 3 lines. And so this arrow represents the PrEP to need ratio for white residents in the West. If we click again, we can see the PrEP to need ratio for the Hispanic residents in the West. And if we click again, we can see the PrEP to need ratio for the Black residents in the West. And this pattern of the highest PrEP to need ratio among the white residents of the region, intermediate among Hispanic, and lowest among Black, holds true for every region that in the US. And then last, I want to introduce the term PrEP inequity. And this red bar that you see here, the distance between there where the Hispanic and Black lines are kind of close together, and the distance between that and the purple line is the PrEP inequity. What we would like to do is raise all these lines, but the first job is to raise the red and the yellow lines up until they're at the same level as the purple line. That would be achieving equity. In looking at these data over this period of time, however, we find that if the height of that red arrow is the extent of inequity, when we look in 2019 on the next click, and in 2021 on the next click, that the inequity in PrEP is actually increasing over time. So we are getting more people on PrEP in all regions and in all 3 racial and ethnic groups, but the extent of the inequity is actually widening because we're doing the pace of putting new people on PrEP who are white and non-Hispanic is outpacing the rate of putting new people on PrEP in the other groups. So on the next slide, these allow us then also to look at these sort of PrEP use metrics by race and ethnicity, by region. So here's state level maps of the South, where we can look at the sort of indications of PrEP equity by race and ethnicity. And so you can see that this kind of pattern really persists across states within regions. Before I just showed the regions, but the same thing bears out at the state level, which is the highest PNR among the white residents in those states, the lowest among the Black, and intermediate among Hispanic. Next slide. So in terms of how we looked at these data and pulled out some messages that we use to try and increase awareness of this issue. For example, Black people in the US represented 14% of PrEP users, but 42% of new HIV diagnoses. Hispanic Latinx people were 17% of PrEP users and 27% of new diagnoses. That's these data that we looked at before, where we say we'd like for those numbers to be equal. And these same patterns played out in the South and in the West, for example, where Hispanic people represented 43% of new diagnoses. We'd like an equitable world would be one in which Hispanic Latinx people were also 43% of PrEP users, but in reality, that's only 22%. So we pull out these sort of insights and put them in infographics, these panels like you can see on the right. And there are a lot of these. I'll show you where to find them on the website. But there are a lot of these that you can just go and pick out. And there are some that are themed around Black, around Hispanic users, around regions. And so you may be able to use them in some of your education and advocacy. And they're nice because you can just download them and they have all the explanation on there. Next slide. The other thing that we wanted to really point out is that in the early years after PrEP was launched, we see that sort of 2014, 2015, 2016 were around 100%, around a doubling every year of the number of PrEP users. And I think this is typical when something new rolls out. The first year, it's not too hard to double because you didn't have many users before. So the pace sort of settled into this like 46% range. But during the COVID pandemic, we definitely saw a dip in the increase, so only 11% increase in 2020 and about a 23% increase in 2021. We also know that this is a national number, and we've talked some about the fact that these trends, this kind of increase isn't the same for every racial ethnic group. The other thing that turns out to be important is whether states have expanded their Medicaid programs. And we know that, like, for example, in 2021, the states that had expanded Medicaid programs had rates of PrEP use that were 1.5 times higher than states that did not expand Medicaid. This work was originally done by our colleague, Aaron Siegler. So the two things we know that have this sort of effect, regardless of everything else that's going on, COVID and other health inequities, the two things that make a big difference are Medicaid expansion and the availability of PrEP programs. And states that have Medicaid expansion and PrEP programs, so that people both have access to primary care and some of those extra costs are covered by a PrEP program, those are the states that have the highest levels of equitable PrEP use. I also want to mention that there's a great predominance of PrEP use among men in the United States, 92% male and 8% female. And I hope by now, when you see 8% female PrEP users, you're wondering how that compares to new HIV diagnoses. So although it's true that most new HIV diagnoses occur in men in the United States, this is still inequitable because about 18% of new HIV diagnoses are among women, but only 8% of PrEP use. And finally, teenagers and young adults have the highest unmet need. This is a group that accounted for 20% of new HIV diagnoses, but only 13% of PrEP users. Next slide. So there are limitations to these data. I mentioned there are substantial amounts of missing race data. We did the checks that we could to make sure that that didn't affect our overall conclusions, and it didn't really vary by region. The PrEP to need ratio is just an equity metric. A lot of times people ask, well, what level of PNR do we need? And the answer is there isn't a set level, but what I'm sort of suggesting that we do is when we talk about PrEP, we start making a discussion not just about how many people in our communities are using PrEP, but whether it's equitable PrEP use. And our PNR calculations also take into account HIV diagnoses. And so if those data have any problems with them, that would also affect our calculations. Next. So I'm sort of advocating that PrEP programs need to be guided by PrEP equity. That's the use relative to the epidemic impact, and not by PrEP equality. If a place says we feel like we're doing a great job because the same proportion of Black and Hispanic and white gay and bisexual men are using PrEP, I would reject that because that's an equality metric, and we know that there's more risk in Hispanic and Black gay and bisexual men, for example. If we use that measure, prevention programs in every region demonstrated decreasing PrEP equity over time, larger gaps in that PNR. And the South is sort of behind it, all other regions in equitable PrEP use, has the lowest PNRs compared to other regions. And we need better programs to provide PrEPs to the communities and people who are at greatest risk for HIV infection. And that's how we'll close this gap, this PrEP equity gap. Next. I also mentioned that an ecological study showed that the PNR is higher, that PrEP use is more equitable when states have PrEP programs, Medicaid expansion, or both. And we know that the South, which is sort of identified as the area as the sort of least equitable and biggest gaps, is an area where Medicaid expansion has happened less commonly. We say that those states have not yet chosen to expand Medicaid. And we just suggest that PrEP equity metrics are a more meaningful way to assess the impact of PrEP programs than just counting PrEP users. Next. Just want to quickly show you where you can find these data on AIDSVu on the next slide. This is a data that we have on PrEP use. You can see that we're providing it at the state level. And the other types of data that you can find, like HIV prevalence, new diagnoses, mortality testing, and continuum indicators are available at different levels, but we really try as much as possible to make data available at the city level by zip code, so you can really see that detail within cities. Next slide. If you go to the AIDSVu site, you'll see at the top a little navigation bar, and so you can choose your state in that first yellow box, and then you can choose to see, rates, in this case of PrEP use by age, by sex, by race. Here we've selected Black, or in comparison to other things like, health insurance coverage or poverty, just to see how those things relate. So this is a way of looking at the data at the state level. Next slide. Within every state, below the state maps are local profiles. And so these will be just depictions of all kinds of different, aspects of information about your epidemic in your state. On the right, you can see the sort of aqua bar at the top right is the PrEP to need ratio graph specific to this state. And my eyes are too bad to see which state this is. And then the next panel below that shows, PrEP use and numbers of users and distribution by race, ethnicity, for example, and age group. So this really is available for every state. And these are all pre-done. The graphs are pre-done. You're free to download them, take a screenshot of them, and use them in your own work. Next slide. We also have a deeper look page for PrEP, and this is really where is a lot of basic information about PrEP, interpretations of some of these infographics that I've shown you. And then we also have, on the next slide, what are called Q&A blog posts. Sorry, these are the infographics. So these are examples of infographics about PrEP some of which you've seen me show today, that you can use in talking to the people that you work with, the people that you want to educate, the people that you want to learn from about this issue of PrEP equity. And so if you look through these sort of infographic decks, hopefully you'll find some that meet your needs. If you have a really specific question that you're trying to ask and you want to do some education with legislators or with providers or whatever, please contact us at AIDSVu, because we can often make you some materials that meet just the data need that you have to do that work. So these are some examples of ones that are already done and downloadable, but you can also contact us to get something that meets your needs. Next. And then the Q&As are just, they're like short, sort of 5-minute reads about different topics. And we've really been trying to be in touch with people who have done a lot of this work on a lot of this advocacy. So Leisha McKinley Beach, Leandro Mena about strategies for PrEP and Black MSM in the South. Aaron Siegler, who I mentioned, has done this work about Medicaid expansion and PrEP DAP programs. And these are constantly updated. So you can just choose the ones that are of interest and read those. Next. So that's what I have. The thing I'll leave you with is please be in touch with us. If you email our AIDSVu email box or connect with us through the site, we will definitely respond to you, and we want to be a resource. So if you're trying to educate folks, raise awareness, change policy, have a conversation with us about what kind of data you need to do that, and we'll try and get you something that looks nice and that's the most recent data, and help you think about what data you might want to use. So I'm going to stop at this point and turn things over to Luis.
Thank you, Patrick. And thank you for those. I didn't know you were the person in charge of producing those reports that I have been using for years. Thank you very much. And we had Leandro Mena yesterday in a webinar with us talking about monkeypox. That's such a coincidence. We know that the Latino community, the Hispanic community, Latinx community, is disproportionately impacted by the HIV epidemic in the United States. Many reasons cause that the Latinos, the Hispanic, Latinx face cultural and societal challenges, including language barrier, mistrust of the healthcare system, also fear for immigration rules. These challenges can delay the diagnosis of HIV in Latinos. In 2019, 21 of the new HIV diagnoses among Hispanic Latinx were diagnosed late, which means they are diagnosed already when the case is advanced in the stage of AIDS. In the same year, only an estimated 51% of Latinos were reported that ever tested for HIV. There's a very low rate of testing among Latinos. Patrick already noted that some of the PrEP use inequities for Hispanic and Latinos, what we face on this topic, but I want to go a little deeper on this. So the Hispanic Latinx people are underutilized in PrEP relative to their needs in the United States. We know the Latinos are a group that requires more because we represent 27% of the diagnosis, but we don't represent, as you see, only 17% of PrEP users. There's a gap here that needs to be addressed. In the West, Hispanic Latinx represent 43% of the diagnosis, but only 22% of PrEP users. Again, the gap that Patrick was showing in previous slides. One of the most important tools in HIV/AIDS advocacy is the power of the visual. Patrick was saying, very importantly, how showing these maps, these graphics, create a clearer vision of what's happening, easier than to understand the numbers if you don't work with the numbers, like many of us do. So visualizing PrEP data, as well as all the other data available in AIDSVu, give you opportunity to understand where we need to concentrate the efforts. Advocates can use the maps, the graphics, the infographics, that AIDSVu produces every year, in every awareness day, to tell a story about a variety of audience, whether that's individual at risk or living with HIV, policymakers, providers, or community leaders. These are the infographics that it was shown before. These infographics are being used by many people. We use it a lot in the commission to share information about HIV, and I really ask you to share this also with your network so people can learn about HIV, PrEP, and many other related topics on HIV in the care continuum of HIV as well. In conclusion, the Hispanic, Latinos, Latinx people have to continue to be part of the conversation about HIV and AIDS prevention. That's what we do, like National Latinx AIDS Awareness Day, because we are still a burden of this health disparity. So new PrEP use maps by race, ethnicity on AIDSVu make it clear that although PrEP use has been increasing consistently in the last 10 years, in the last more than 10 years now, the progress has not been shared equally in all communities across the races and ethnicities. Black communities, Hispanic communities, Native American communities are not receiving the amount of PrEP that they should be. So this weekend on the 15th is National Latino AIDS Awareness Day, which is a good opportunity to recognize the unique challenges that we Latinos face in the area of HIV. So now we're going to go to the question and answer. Please write your questions to Patrick and in the Q&A box, and we'll try to answer.
Yeah, we can answer these. We can answer these together. We already have a couple, and I really appreciate starting with great questions, which I'll read, and then I can take a stab, and at least you can help me out. So Yuri says, the number one barrier or challenge to access PrEP, like most prescription drugs, is the lack of coverage, insurance. So how likely will it be to have government-sponsored program to provide free or low-cost PrEP? And how likely will it be to acquire a generic option for PrEP, like Teva's FDA-approved generic version? So what I can say about this is that, the evidence that we have, Yuri, I think exactly backs up what you're saying, which is that the levels of equitable PrEP use are higher in places that have Medicaid expansion and places that have PrEP-DAP programs, which cover, some of these PrEP-DAP programs will cover like buying the medicine, but not the doctor costs. Some of them will cover the doctor costs, but not buying the medicine. But, they're basically pieces of what you're talking about here, which is, a program that just really makes it no or low cost to get PrEP. And in places that do that, there's more PrEP use and there's more equitable PrEP use, meaning that lowering those barriers that you're talking about helps Black and brown people more, which is what we want. In terms of how likely it will be, I was just at USCHA, and I know that there is a lot of discussion about advocating for a national, free or low cost PrEP program. Right now, I think the opportunities, in my view, that we have are, I live in Georgia, a state that has not yet, adopted Medicaid expansion. And I think any of us who are in states in that situation have something that we can do locally. And also talking about PrEP-DAPs. But I do think at the same time, we need to be talking about a federal, nationwide solution, so that it's not like if I live in Georgia but move to Kansas, then I have trouble. A colleague of mine at Emory, some of you may know, Travis Sanchez, has been talking about HIV rapid tests and distribution, and the language that he uses is we need to remove all of the barriers that we can, like all of the possible barriers, we need to lower them. And if what we can do in the first, like today, is to work locally to do that like Medicaid expansion and PrEP-DAPs will lower a certain set of barriers. Another set of barriers is barriers associated with moving or living in different places. And so that may take a national, program, and we may get there one step at a time. There is a generic option, for PrEP now. And so I know that that some people are benefiting from using a generic option and getting PrEP protection. So I think that's available now and in discussion with the doctor. So Luis, you want to add anything to that? Just like, how do we move towards a government-sponsored program?
I think I'm very lucky people who live in the city of New York or in the state of New York. We're very lucky that things are different here, where Medicaid expansion happens. And on top of that, there's different resources for people living with HIV or risk of HIV. I think we were the first state to implement in the epidemic plan. And with that, there was a lot of change that happened back 5 years ago. But I think if you are living in a state like yours, advocates are strongly the principal people to intervene in these things and advocate for expansion of Medicaid or different types of insurances. Here in New York, we're still working and advocating hard to try to get insurance for everybody, whether they are documented or undocumented, because in New York, there is a lot of undocumented individuals that require medical treatment and HIV prevention. Because if we only cover people who is a citizen or a resident, we still have a big chunk of people that are not covered. And if we don't cover these people with PrEP or with things that are going to treat their HIV, we are not going to stop the epidemic. So it's important that everybody, independently of the immigration status, get treated or prevent or receive prevention medication for HIV if we really want to end the epidemic. So a lot of work here to do in the areas where the facilities are not as they are in states like California or New York.
Yeah, thanks. And thanks, Yuri, for that question. The next question is from Alexa, and Luis, I think I'll let you take a first crack at this one, which is what can we do to break down language barriers?
It is a hard work to do. I mean, I work in a commission and we do everything bilingual. Every document that we produce is bilingual, but because we are Latinos and we want to reach our community, but I think there are organizations that, even though they do not work with Latinos, they still should try to produce documents in Spanish, because the Spanish population in the States is very high. We are 17-19% of the population these days. And many of the Latinos do not speak English well or do not speak English at all. But Spanish is not the only language. There's so many immigrants from different countries that speak French, speak Italian or any other language, and native languages from Latin America as well. So there's a lot of work to do here on language justice. We started at the commission to do this year, and we're trying to break down these language barriers, but we know that it's very difficult. And I think local governments need to understand the needs of their local population and the specific populations and try to do something about it, because areas in New York, for example, I'm going to talk about New York because that's what I know most. In Queens, in the area of Flushing, it's very Asian community where Chinese, Thai, Japanese needs to be, Korean needs to be implemented. So they produce, the Department of Health in New York produce documents in every language as possible, and they distribute it in the areas where this population is. So that's I think that's the first step. But going through this problem of language barrier is one of the biggest problems that immigrants have when they arrive here to the States. So also implement governments, local governments can implement places where the population can learn English as a second language. That's a very important thing to do as well. It's expensive for people who come here to the States to go to school to learn English. So something has to be done by local governments to help these immigrants to learn English as well.
And I want to thank Alexa for that question and Luis for that really thoughtful response. And I also just want to, in terms of the discussion we're having today, this is a perfect example for me of, what do we need to do to increase health equity or to decrease that health inequity. And it seems, it seems like that our friends shouldn't have to raise this, but like you're going to be more likely to use a health service if it's provided in the language that you use, and you can ask the questions that you need to ask. I mean, this is a conceptually hard intervention. The fact that you're taking medicines that have been used to treat HIV, but now they're to prevent HIV, and it doesn't mean you have HIV. And people have these questions, and the nuances of language mean everything to people's decision about whether this is the right thing for them to use. So I think this is one example, like really concrete example of steps that could be taken to increase health equity, to narrow that inequity. So I appreciate it being raised. And along those lines, Jasmine asks whether the slides and data are also available in Spanish. So all of the National Latino Awareness Day, AIDS Awareness Day infographics are available in Spanish. We're sort of working to translate more of our materials into Spanish as we go. We've typically done a subset of them, but I would also say if there are things that you see on the site, infographic panels that you want to use in your work, and it would be helpful to have them in Spanish, we're also helpful to move up those in the priority. So if you just email info@aidsvu.org or go on the AIDSVu site, there's an email address or contact us. Again, like we have a team of great colleagues who are happy to engage and get you the materials that you need to do your work. And so that will help us prioritize, because that is something that we're moving towards. So you can, I think if you go on, you'll see there's a important subset of stuff that are in Spanish, and these inequity slides are also available for the Latino AIDS Awareness Day slides are also translated.
Yes, you can also go to enla.org. We have material in Spanish, but also in CDC, NIH, other governmental offices about health, they have sections in Spanish and documents in Spanish. You can also download. Also the website with inequity, Prevention Access Campaign, they also have documents in Spanish. So there are several resources that you can find online in Spanish. Another question.
A question? Oh, you're welcome, Jasmine. Thank you for the question.
Any other question, Patrick, you may have?
Well, Luis, I'm going to give you the last word if there are no more questions, but I'll say one thing before, which is that I appreciate this opportunity to present with you today, Luis, and the Latino Commission has from the very, like AIDSVu is now, when did I say we started? We're now at least 12 years old or 13 years old or something. We're getting into our terrible teens. But the Latino Commission has been a real partner from the very beginning in AIDSVu. And so we appreciate your partnership and the work that you do, and especially appreciate the chance to present with you today, Luis. So thanks for all that you've done for AIDSVu and for this partnership and for our presentation today.
Well,
and I'll let you have the last word.
The Latino Commission is always very happy to partner and collaborate with AIDSVu and HEPVu as well. And we have almost every year presentation on AIDSVu and NLAB, because we consider it's very important for the population, people who work on the HIV field, learn how to use this webpage, because it's very important. All the data that you produce and the graphics are incredibly helpful in the work that we do. So that's why we always invite AIDSVu to have a webinar, and it's always new information that's coming out. As you mentioned through the years, how AIDSVu has been evolving and changing and producing more detailed information. That's amazing. So thank you for providing this webinar with us and helping us disseminate the information. I joined the Latino Commission as staff. You can go to the webpage that we have. It's latinoaids.org, and there's opening positions published there, or you can contact me, send me an email, and ask me what you want to do with the joining the Latino Commission AIDS. Erica Thompson asks, some of you in other states have reached medical expansion. Can you share some ideas? How can we reach medical expansion in Mississippi? Missouri? No, Mississippi. Well, here in New York again, I'm going to New York. Things are a little easier perhaps because of the type of government that we have in the state is more democratic and liberal than other states. And they're more open to listen to advocates and try to work together with advocates in these type of things. I understand that the South states are kind of, which they need the most because that's where the epidemic is hitting harder, but the governments of the states are not as liberal and progressive as we are, or as California is, or other states are. And that's a big problem. I think election campaigns, voting the right government is the first step for you to be able to get to these levels of health management like New York, California, and other states has done, but politics is very much involved in this. Unfortunately, it's something that shouldn't be. Like health is a right that we all should have. We have a right to health, but it is not the same in every state, in every county, and every city. So voting is the first step. I think is very important, and promote your peers, your groups, your colleagues, your friends, family. They need to go and vote. People don't go voting enough. So I think if we all go to vote, things will change. That's the first step. And then advocate, create a plan with your points, and go advocate. Call your local representative, call the senator, and talk about these things and how important it is for you and for your community to have expansion. And only you doing that and people around you doing that over and over again, perhaps you're gonna try to convince the representative they are the ones who make the laws. So all we can do is bring the ideas and bring the topic to the table, and they have to do something about it.
I agree that this is something that, like, there are so many issues swirling around right now. We're obviously in an election season, and it feels like there are just so many things emerging every day, like new issues. But I think we have to make sure that that politicians are asked about their position on this. If they say they're not in favor of Medicaid expansion, I'd ask why. I think that some of the reasons that are presented for politicians not wanting to expand Medicaid don't hold up very well if they have to explain them. So I agree that, like, raising this discussion, making people aware of it, voting for sure, but also asking candidates to state their positions and justify them, because it's hard to, in my view, it's hard to make a strong case that it's not better to have more people with a basic level of healthcare protection and services. So make them try.
No. Any other question before we close? We still have a few minutes. No. Thank you, Patrick, very much for joining us today on this incredible informational webinar about AIDSVu and PrEP. I invite everybody to tomorrow. We have another webinar at 3 p.m. It's going to be about vaccines on HIV and the progress that has been done on vaccination for HIV. You see, we don't have a vaccine yet, but something is being done. And if you want to know where we are at that, join us tomorrow at 3. And next week on the 20th, we have the last webinar for NLAD, which is going to be about U prevention campaign. I think there's a couple of questions here.
Yeah, I'll handle this last question, which is how high is the sort of PrEP use in harm reduction programs? And the data that we have don't really calculate this in specific programs, but I think that there's an opportunity probably to introduce PrEP in harm reduction, settings, and I think we can try and follow up to see if there are any examples. I'm trying to think if we've covered any of those. Pedro, if you will email AIDSVu, just like info@aidsvu.org, so that we have your email address. I'll try and see if we've covered anything or had any of those interactions. But I think this is a perfect example of a place where PrEP needs to become part of a comprehensive set of tools, and when someone comes into these programs, PrEP may not be their first and most immediate need, but a lot of the services that are provided actually go hand in hand with creating opportunities for PrEP, which might mean trying to find coverage through existing health insurance programs or Medicaid if there's a state that has Medicaid expansion, helping people with housing opportunities, because we know from our experience with PrEP users in Atlanta that it's hard to really get on and stay on PrEP if you don't have a stable housing situation. So I think PrEP really makes a lot of sense as part of a package of interventions in harm reduction. And we may know of some examples of places that have done that. And if so, we'll send that on. It's a great question.
I think All right, thank you again very much, everybody who joined us today. I hope to see you tomorrow again. And thank you, Patrick, very much for delivering.
Thank you. Have a great day. Bye-bye.